Thank you very much, ma'am. At the outset, I would like to thank AIOS for giving me this opportunity to speak in front of this August gathering. This is a very important topic and that has to be covered in just 7 minutes, so I'll try to give justice to it. Anterior vitrectomy, in case of PCRs, what we'll be discussing about. So the posterior capsule is the thickest basement membrane of the body, and mind it, when it is stretched more than 60% of its tensile strength, then it breaks. So that is why many a times you get caught in your aspiration probe, but it doesn't give way. So what are the interop events that lead to accidental PCR? Most common is the IA, then extension of the radial tears, large leaky wounds, vigorous hydroresection during removal of the last fragment of nucleus, during intraocular lens placement and dialing, incomplete capsular access in which the tags of the rexus can be caught and lead to a PCR and extension of the tears to the, beyond the equator. Then hydroprolapse of the nucleus to a small rexus, manipulation of the bag without adequately pressurizing it, during polishing of the posterior capsule or by direct hit by a phaco probe, chopper or a dialer. So these are the events in which we can have a PCR. So management of PCR, it depends on, it requires three things. One is the immediate management. Then you require a tailor-made plan according to what all things are left behind inside the antechamber. And third, and the most important thing is counseling. So how to recognize if a PCR has occurred? By sudden deepening of the antechamber, or by a momentary dilatation of pupil, which is known as snap sign, sudden brightening of the frontal globe, the nucleus starts paradoxically moving sideways, or it goes inside the vitreous cavity. So you are sure that a PCR has occurred. In the management of PCR, the most important thing is maintaining the anterior chamber. So now you don't use the main incision. You have to have two side ports so that the chamber is always pressurized. The most important thing and the most biggest, what is the most biggest problem is, once you see a PCR, in a hassle you remove the phaco probe. That has not to be done. Whenever you think a PCR has occurred, first fill the anterior chamber with your non-dominant hand with viscoelastic. A dispersive viscoelastic has to be put inside the anterior chamber, and then when it is adequately pressurized, then you need to remove the phaco probe. Because what happens, if the chamber collapses, the more and more vitreous will come inside the anterior chamber to the PCR end, and it gets enlarged. So a case that was manageable initially becomes a mess. So finding out whether it is, the vitreous is there or not, then you need to go for anterior vitrectomy. So how to recognize if vitreous is present or not? You can switch a swunge or a swab on the side of incision. If the vitreous has come beyond the incision line, then you can come to know about the presence of vitreous by movement in the anterior chamber. You can insert a spatula or from the side port and sweep, or the best is to stain with a time solenoid. So whatever amount of vitreous is there inside the anterior chamber can be seen. Sponge vitrectomy, which was initially done, is obsolete now because of the intense pressure that it exerts on the vitreous base, leading to breaks in the post-op. Automated vitrectomy with a bimanual technique is very important nowadays, which is usually used. Now this is done through a side port, which makes the chamber completely closed. We start the vitrectomy from the incision, the main incision, so that if whatever vitreous has come till that can be cut first. Then you go inside with your cutter facing upwards, and then the part of the vitreous that is there at the PCR, that is dental at the last. So the first thing is, don't panic, put some dispersive viscoelastic, and then if, like in this case, there was just some amount of cortical matter left, it can be removed just by dry aspiration of the cortical matter. Whenever you do a dry aspiration, some part of vitreous will again come inside the anterior chamber. You need to go ahead and do a dry vitrectomy again, and then go ahead with this thing. What the parameters, it has to be high cut rate with low vacuum, and flow rate should be used. This was from the limbal route. The second type of vitrectomy that can be done is from the pars plana, which is more physiological. Why I'm calling this more physiological? Because in a pars plana vitrectomy, what I'm doing is, whatever vitreous has come inside the anterior chamber, you are just transecting that. So there is practically no pull at the vitreous base. So if you don't have a trocar system with you, most of people, they have MVRs with them. You are making side ports with MVR. You can use that MVR. You can stab directly at 3 mm from the limbus, go inside and do the pars plana vitrectomy from that, which is more physiological. Now, what in this case, what happens is, when you're doing a pars plana vitrectomy from the, we are doing vitrectomy from the pars plana route, your cutter faces downwards, so that you don't hit the posterior capsule, and you can use that for implanting IOL. While when you were using the limbal route for plasma vitrectomy, for vitrectomy, the cutter was facing upwards, and only once you reach the posterior capsule, the PCR place, then the cutter goes downwards, it faces downwards, and you go inside the vitreous cavity. Now, confirming the completion of vitrectomy, again using a triamcinolone nitrate, that is the best way to confirm that vitrectomy has been completed. Now, once you know that vitrectomy has been done, how to manage the nucleus if it is there inside the AC. So, if there is a PCR with hyaloid face, but the hyaloid face is intact, that means the vitreous has not come inside the anterior chamber. You can actually put some dispersive viscoelastic inside. If the junk was small, go ahead and finish it with a burst of Fico energy. If it was a large fragment, then you need to increase you need to extend the incision and remove it through a glide or something. That is, you'd convert into an ECC. Similarly, if the hyaloid phase was ruptured and some vitreous has come inside the inner chamber, you need to manage that with vitrectomy first, and then the events are same. Now, if there has been a posterior capsular tear and the hyaloid phase has ruptured and the vitreous, the nucleus has gone inside the vitreous cavity, anterior segment surgeon should not manage beyond this, because if you're going to manage beyond this, then there would be a mess. So it is better to, if you have a standby VR surgeon in your AOT, let him finish the case after that. Or if you don't have a standby VR surgeon, close it, and then you can send the patient to a VR surgeon for management. What is required in such cases is the 3-port pass-me vitrectomy is required with FICOFRAC, and PFCL is used to float the nucleus so that it can be emulsified away from the retina. The IOL implantation, it depends. If the nucleus was soft, you can go ahead and implant an IOL. If the nucleus was very hard, if it was a case of brown cataract or a cataract nigra, you leave it for us. We can sometimes remove the nucleus from the limbal root also. IOL placement, it again depends on the site and extent of the rent. And if the tear was small, you can go inside and put the IOL inside the bag itself. If the tear was larger than 6 millimeter, then a 3-piece IOL is preferred, which is put into sulcus, and you can do an optical capture in this. And if the capsular support was inadequate, you can go for AC IOL, SF IOL, iris fixation, or internal fixation. Counseling, it starts from the moment the PCR occurs. The patient, because he comes to know that something has happened if the OT atmosphere changes. So you need to be very well versed with such situations. Your staff has to be very well versed. आपके इशारे से उसको समझ में आ जाना चाहिए कि हाँ कटर निकालना है और कटर रेडी होना चाहिए. ये नहीं कटर कहीं रखा हुआ था और वो मिल नहीं रहा है. तो staff has to be well versed. और OT में कोई बात नहीं होनी चाहिए. पेशेंट सब सुन रहा होता है. हमारा पेशेंट जो है वो बेहोश नहीं होता. वो सब सुन रहा होता है. उसे समझ में आ रहा होता है कि कुछ तो गड़बड़ हुआ है. So the counseling of your staff is very important in such cases. And after that, once the patient is out, then the counseling of the relatives. That is very important, that something has happened. So what I usually ask my friends to tell them is, झिल्ली कमज़ोर थी, जिसकी वजह से कुछ न्यूक्लियस का पार्ट जो हमने निकाल लिया, कुछ जो है वो VR सर्जन को मैनेज करना पड़ेगा, इसके लिए हम उसके पास भेज रहे हैं. Then you should have a very good rapport with your VR friend, जो कि आपको कम से कम चार्ज में उसको मैनेज कर दे. So this is what PC rent is, how it is managed. Take home messages, don't panic. The first thing is, you all should start using your non-dominant hand for putting viscoelastic from the side port, so that even if you get such an incidence, you are well versed with putting in viscoelastic from the side port. And secondly, your table-made plan is very important. Sit for some time, think what is the situation, and then act accordingly. Thank you.
Thank you. I just want to know, how do you do the ishara to your staff to get the cutter?
तो मैं बस यही कहता हूँ कि that one person knows, if I say, that means cutter is required now.
So one of the most important things, whatever he said about the presentation is very good, but whenever something happens in the OT, I think it's very, very important that immediately you stop your neck surgery, go outside and talk to the patient attendant. That is the time the patient attendant and the patient is most forgiving. They know complications can happen. But if you have finished a whole day's work and then in the evening you go and tell that patient who you operated in the morning that there was some complication, then they will not be so forgiving. But if you call them to the changing room and if you talk to them, sit down with them and tell them what happened, they are most forgiving and understanding at that point of time.
Yeah, this is important. Why? Because the amount of time that you have involved in this case was more than what was in the previous cases. So you need to justify that to the relatives. Otherwise, what happens? It keeps on piling, more and more questions keep on piling, and then the patient and the relative are not very satisfied.